Η συνεδρίαση που θα ακολουθήσει είναι μια πολύ ενδιαφέρουσα ομιλία για την εκπαίδευση στις ενδοσκοπικές τεχνικές. Δεν ακούμε συχνά ομιλίες που να αφορούν την εκπαίδευσή μας και την εξάσκησή μας στις τεχνικές. Σήμερα έχουμε την χαρά να έχουμε μαζί μας έναν πολύ έμπειρο συνάδελφο, ο οποίος δουλεύει σε ένα από τα μεγάλα κέντρα εκπαίδευσης στην επεμβατική πνευμονολογία στην Ολλανδία, στο Άμστερνταμ, με ο Πίτερ Bonta. Από εδώ και πέρα θα σας μιλήσω στα αγγλικά για να μπορούμε να τον προσκαλέσουμε. So, Professor Dr. Bonta is with us today. Thank you very much for being here. Dr. Bonta is involved in many educational activities in Netherlands, in Amsterdam, and one of the biggest centers of education and training in interventional bronchoscopy, and especially in ultrasound and endosonography. So, he will address the subject of training in thoracic endosonography in the area of competence, assessment, and accreditation. So, Dr. Bonta, thank you for being here.
Well, thank you very much for this kind introduction. And of course, I'm very honored that I was invited to give a lecture here on endosonography training here in beautiful Athens. It's really a pleasure to be here and to be part of your Pan-Hellenic Thoracic Conference. My talk will be on endosonography in the area of competence and accreditation. And these are my disclosures. Most are not that relevant for this talk. However, we do a lot of courses also in endosonography, and for this Pentax, Hitachi, and all needle companies and Fuji are involved in this. So basically it comes down to skills. That skills are really important for the pulmonologist. And from 1966 on, actually flexible bronchoscopy was introduced, as all of you probably know, by Professor Ikeda. And it actually opened a whole road to to actually look into the airways and provide novel diagnostics, both of the airways and the lung parenchyma, but also to all other types of interventions. And actually thereafter, there was this big shift towards endosonography. And it started in 1993, when it actually became technically possible to introduce a scope with an ultrasound head into the esophagus, not to look into the esophagus, but to look through the wall of the esophagus, to see what is behind. The lymph nodes and other structures could be visualized. Again, 10 years later, the endobronchial ultrasound was introduced, which made it possible from the airways to visualize structures around the airways, lymph nodes, in the mediastinum, but also in the hilum of the lung. And as such, minimal invasive endosonography, as compared to mediastinoscopy, has really been shown to be a practice changer, we can call it. It has a central role, as has already been elucidated on by the previous talks, in lung cancer diagnosis of the tumor, in staging of lymph nodes, and detecting metastasis, including even the left adrenal gland. But also in sarcoidosis, it has become really important. I will come back to that in a minute. And actually the upper picture you see is an example of an endosonography picture of a patient with sarcoidosis, showing these typically clusters of nodes visible. These are isoegoic and can be hypervascularized. Tuberculosis is also important with this respect. It has a different aspects, actually the picture below. In these nodes, there are more hypoechogenisic areas, and by biopsy, these nodes, tuberculosis, can often be diagnosed. The other indications exist. These are mediastinal metastases from other thoracic tumors or extrathoracic tumors that can metastasize, can be detected. And also in the lymphoma diagnostic, it has a role, although there is the issue that most often, especially for a primary lymphoma, real tissue needs to be, tissue course needs to be sampled, and this is often difficult so far with endosonography, although there are needles now being developed that aim actually for a real tissue diagnosis as well. And finally, we can detect cysts with this technique that can be present in the mediastinum actually you should not biopsy these because these have a very high risk of getting infected and causing a mediastinitis. So endosonography in lung cancer has a very prominent role, and the majority is actually staging. And what I try to show you here is that there are differences in EBUS and EUS in terms of staging in lung cancer. This is one of the famous drawings of our appreciated colleague, Dr. Paul Clemenson from Denmark, and he is very involved also in the training program for EBUS, in the European training program. So you will see several drawings of him during my presentation. And actually what you can appreciate that the yellow and the green nodes are accessible with EBUS, and these consist of all the mediastinal nodes and the hilar nodes. And there is overlap with EUS, and these are the greens as well, but the yellows can add, the blues can add to this. And this is the lower mediastinum, so lymph nodes 8 and 9, but also the organs and structures below the diaphragm, including the left adrenal gland, the celiac lymph nodes, and liver metastasis. And this has resulted in the concept of so-called complete staging. By combining EUS to EBUS, you have actually reached to all predilection sites for lung cancer metastasis. And this was even taking a step further by the possibility to introduce the EBUS scope into the esophagus, which is called so-called EUS-B. So that means with a single scope in a single session with a single operator, we can do a full lung cancer staging procedure. And not only in staging, it has a crucial role, but also in the primary diagnosis of lung cancer. This is really important. And that means that, for example, tumors that are adjacent to major airways or to the esophagus can be easily accessed by endosonography. And also, for example, we've performed studies on assessing T4 status by endosonography, and this is very well possible by using endosonography. On the other hand, it's also possible to get enough tissue for all the molecular analysis, mutational analysis, but also immunohistochemistry analysis like PD-L1 expression that needs to be done. This paper has been presented before, so we'll go over it shortly. But it showed actually, this is one of the few randomized controlled trials in this field where mediastinoscopy was compared to endosonography for mediastinal nodal staging in lung cancer. And it showed, as previously told over, that the diagnostic yield for mediastinoscopy in the mediastinoscopy group was 79%. However, the combined approach, so adding having endosonography previous to mediastinoscopy, had a diagnostic yield of 94%. And this meant, in more practical terms, that 11 patients needed to undergo mediastinoscopy after negative ERS EBUS to detect a single patient with N2 disease. And this has shown to be actually a complete practice change and has resulted in an adaptation of the guidelines of mediastinal nodal staging for suspected and proven non-small cell lung cancer. So if you have a patient like this and it has abnormal mediastinal and hilar lymph nodes based on imaging, then endosonography is recommended over invasive surgical staging as the initial diagnostic step. So I promised to come back on sarcoidosis, and actually for sarcoidosis, especially suspected sarcoidosis stage 1 and 2, it has been shown that endosonography has a really good diagnostic yield of around 80%, and this was actually found in a randomized controlled trial. It's called the granuloma trial. It was published in JAMA in 2013, where it showed that endosonography was much better in granuloma detection as the standard diagnostic strategy, and that included bronchial alveolar lavage, transbronchial lung biopsies, and mucosal biopsies if indicated. And with this trial and several other trials that have been also analyzed in a meta-analysis in 2012, it is stated that endosonography is the test of choice when granuloma detection is indicated. So to come back to training, why is endosonography training so important? And well, I think this is because all these trials have nice results, because all these trials are performed by EBUS experts, endosonography experts. And of course, the success depends on the skills of the endoscopist. And for these complex procedures, we know that there is a significant learning curve. And on the other hand, there's also an increasing society focus on medical procedures in general in terms of quality control and patient safety. So what is there around for endosonography training in 2019? Well, you have actually many tools and possibilities you can choose from. You can choose from simulators nowadays, you can choose for assessment tools, e-learnings, videos, and courses. But a structured program to train endosonography has only recently been developed. And that's what I would like to focus on, and also a bit on the backgrounds of that. So how should we train endoscopists and endosonographers? There are basically two models, and the first model is the apprenticeship model. And everybody knows it probably in the audience. It's see one, do one, and teach one. It's actually not a really structural approach, but you learn it from a master in this order. And we also know this is actually not optimal to learn complex clinical procedures. And why not? Because the learning curve is not as efficient as it can be with simulation-based training, and you start with a very low level immediately in patients. And actually that's not what we think is the right way to go. So we know well from other fields, for example, the aviation industry, that simulation-based training can help you with this. It would be rather strange if a pilot has his first flight in a real Boeing. Nobody would accept that, actually. I would not like to be in that plane. But with simulation-based training, you can increase your level of competence without any risk, and even be more efficient in learning procedures. And that is shown on the right graph. So, but before we can do something like this in endosonography, we need a sort of systematic approach. And this has been developed and has already been mentioned before. And it has a structural order of sampling and assessing lymph nodes in the mediastinum. And it starts by simply introducing your EBUS scope into the airways and make sure that you're in the airways. The second is that you turn to the left and look for station 4L. So it's between the aortic arch and the left pulmonary artery. The next station thereafter is station 7, the subcarinal station. You can approach it either from the left main bronchus or from the right main bronchus. Thereafter, you will put it into the left main and visualize 11L and 11 and 10L. The next one is go to the right main bronchus. Visualize the hilar on the right, so 10-11R, and then you retract it back, we'll visualize the esophagus vein, and the esophagus vein is actually the border between 10R and 4R, and that will finish your systematic approach. And it sounds a little bit complicated, but it's actually not. You can do this if you're well trained in this and you have your own systematic approach. You can do this in 2 minutes in a patient, and then you're sure that you have seen all the landmarks, you have seen all the stations, and it gives you a systematic approach. And this is actually, for us, nowadays, we actually, for example, don't need a CT anymore, because we just do a structural approach and see what we can visualize. Of course, it's not completely true, but a similar systematic approach has been developed for EUS. And, well, it focuses on the structures below the diaphragm, so the liver, the aorta and left adrenal gland, and the stations that can be reached with EUS, and that is most importantly 4L and station 7. 4R is in this graph, but is much more difficult actually. So the other thing that needs to be done when you want to train in a structural way endosonography is the biopsy technique. And the biopsy technique is that you have your EBUS scope into the airways, you advance your needle, you will set the sheet, you will approach your transducer to the airway wall, you will position it adequately and introduce your TBNA needle and do your passes. The other thing that is really important, especially in lung cancer patients, is that you keep the right order of biopsying this to prevent upstaging of the patient. So go always from N3 to N2 to N1 to the primary tumor if that is within reach. So this has resulted in this called EBUS assessment tools. And it's actually a way to assess how someone performs an EBUS. And the first part is about introducing the EBUS scope into the airways and orientation on anatomy. So you will recognize the landmarks there again, 4L, 7, 1011L, 1011R, azygous vein, and 4R. And the second part is on how you actually perform your biopsy. So positioning of the transducer, use of the sheet and needle use. And this EBUS assessment tools has been tested in a randomized way. In this study, residents were randomized to either the apprenticeship model or to simulation-based training. And it showed basically that simulator training was more efficient in getting a higher level of competence as compared to the apprenticeship model with using this kind of EBUS assessment tools. On the other hand, it was also clear that it was not possible with this training to reach the level of EBUS experts. So from that time on, in the latest guidelines, it's also mentioned that new trainees in endosonography should follow a structured training curriculum consisting of simulation-based training and followed by supervised practice on patients. And for this reason, in 2014, the ERS decided to support the launch of the structured ERS EBUS training program. And these are all the people involved. So the Danish group with Paul Clemenson and Lars Konch from the educational part, Felix Hurt from Heidelberg, Maren Schumann and Jouk Annema from Amsterdam. And the aims of this ERS EBUS training program was to train qualified doctors to be able to independently perform EBUS and to ensure knowledge and skills required to obtain ERS certification in EBUS. And the target audience for this course were qualified MDs with previous experience in bronchoscopy and diagnosing and staging of pulmonary oncology patients or other diseases relevant for endosonography. And this ERS EBUS training program consists of 3 parts. The first part is a theoretical training. The second part is clinical and simulation-based training. And the third part is supervised training. And I will now go a little bit more in detail on this. So part 1, the theory, it provides actually the trainees relevant theoretical knowledge on EBUS. And this is about 7 online modules. It's anatomy, landmarks, contraindications and indications, imaging modalities, and basic ultrasound knowledge and complications. And these online activities must be completed before attending the on-site course. Then there is the on-site course. It's a 2-day course which can be followed in Heidelberg, Copenhagen, Amsterdam, and in the near future also in Ancona and in Athens here. And during this course, the theoretical content is revised, and you have a very close interaction with the faculty. There are hands-on sessions, so EBUS stations are there where you can practice yourself, and you will be able to see live procedures streamed to the room, doing the EBUS expert doing the procedures. And after this part 1, there is an online MCQ question assessment that will finally certify you for this part 1, and these questions are also validated in publications. So part 2 is a 2-day clinical observation and simulation-based training, and the training centers are similar as meant previously, and you are only there with 2 participants, so that gives you in these 2 days a very close interaction with the faculty. And it's all about safe handling of the EBUS scope. It's learning about the 6 landmarks, but also disease pattern recognition, performing TB&A, using the EBUS assessment tool, not only for yourself, but also you can rate the EBUS experts, and it's finalized with an exam on the simulator. So this is how we do it in Amsterdam. We have a team, we have the endoscopy suite and the simulator-based training next to each other, so there's a very easy interaction. And of course, it's a nice city as well. Part 3 is the supervised training. It is, of course, it's needed because, simulation-based training can never be 100% realistic. And you need to do it on your own, finally, in real patients. And to do this, you are requested to build up a portfolio of 20 EBUS procedures and record 3 videos, and these will be graded and reviewed centrally. So, in summary, the ERS program looks like this. It's about theory, it's about simulation-based training, and it's about supervised training, and it includes examination. So finally, I would like to share with you a bit on a novel technique, and it's called needle-based confocal laser endomicroscopy, and its role in lung cancer, and it has been published this summer in the ARJ. Confocal laser endomicroscopy is a novel imaging technique that can provide you with microscopy imaging, in fact, in vivo real time. And it consists of probes that can be advanced through the working channel of a bronchoscope or even through a needle. And this is what you can expect when you advance such a probe into the alveolar compartment of the lung. And we're currently investigating this technique in interstitial lung diseases. This is the EBUS needle-based approach. And actually, through this 19-gauge needle, you can advance such a probe, and with the probe inside, you can target a node, and you need to visualize the cells there, an intravenous dye called fluorescein. And this is how it looks like. So on the left side, you see the 19-gauge needle being pushed into the node, and then finally, you see also the probe is advanced. You can actually see it sliding in now. And then you will see the picture on the right, in which you can actually visualize dark, enlarged cells that sometimes have also a characteristic that's called directional streaming. So this was in a lymph node, and this actually, in this next picture, is on a centrally located lung tumor that was adjacent to the esophagus and approached by this technique. And actually, this was, in our view, really amazing that you can, know for sure that your needle is in the right spot, and it adds to the principle of a so-called smart needle that knows where you are. A similar approach can be done for the peripheral lesions. As already talked a lot about, we use for this approach radial EBUS combined with fluoroscopy, mostly. And again, NCLE can provide you with images on if you have hit the tumor, yes or no. So in summary, endosonography, I hope I've showed you that endosonography has an important role. It's really shown to be a practice changer in lung cancer and sarcoidosis, but has many other applications. There are novel developments there as well, in the navigational area, including radial EBUS, but also in NCLE. And I think it's also really important to stress that the quality of endosonography is really dependent on how well you are trained and on your final results. And there is a very nice ERS trainings program. And we as a group are also very happy that Athens will organize the next part 1 in the beginning of October of 2020. I thank you for your attention.
Thank you very much, Peter. I conclude that the steps are 3, the theory, the simulation-based models, and the supervised training on patients. I need 2 hot questions. Too cold, maybe. Okay, that's good.
Thank you very much for a very nice talk. We aim to structure the algorithm for education as well. Could you give us some insight about your last slide about Cellvizio? Did you have results that you can actually really grasp? You see that there is any room for this modality in the EBUS, or it's just for the moment in theory?
Well, no, I think there is room for this technology. So for endosonography, we already have a publication on this. Obviously, it is in the field of research and it needs more validation and in larger patient groups, and we are also working on that. Yeah, so I think the idea that next to navigational technique, actually it comes down that you are absolutely sure that your probe or your needle is in the right spot. And I think this technique might really add to that. Yeah.
Thank you very much for the presentation. I would like to ask you about your opinion on the role of augmented reality glasses on the training of bronchoscopy, possibly imagining new practitioners using augmented reality glasses to verify and take some real-time information without pausing during their attempt to do the first bronchoscopy on patients. Thank you.
Well, to my opinion, this is, as far as I know, this should be completely new. I'm not sure if there's any experience. Do you know that? If there is experience in this field with augmented reality?
Well, there is some experience on other fields, not in bronchoscopy, but as a resident, when I would like to perform bronchoscopy on a patient, I would like to have maybe real-time feed on the placement where I am, if the site I'm sampling could be cancerous, something that years of experience on another bronchoscopist can be translated in direct feedback. Or maybe also a CT guidance on the field of view while doing bronchoscopy.
It sounds to me as sort of a next generation simulation training.
A nice
would be really cool.
A nice feedback could be rapid on-site evaluation on EBUS.
We actually have some ideas to adapt with narrowband bronchoscopy to measure fractal dimension on tumors, to have a rapid on-site evaluation.
Well, to come back on rows, actually, this is something that we sort of implemented in our endoscopy suite. So when we perform EBUS, there is a cytologist in the room next to, but the video is, the screen is connected to the microscope. And as soon as she shows us the slides, what she performs, so it's not in an augmented, really, but in the room we have the rows available immediately, which is, I think, very nice.
I would like, first of all, thank you for the talk, and I would like to come back to the education and training problems. I know that there's a small number of people who have completed all 3 parts of the course. And I wonder why, and maybe what is the main obstacle, in your opinion, for the passing from theoretical or simulation practice to patient's practice? Is it that people are afraid to go on? Is that they don't have a lot of home institutions to deliver them mentorship? What is, in your experience, the main obstacle, the main problem for not completing the course?
Yes, so we know that a lot of participants do succeed for part 1. There's also quite a lot that do succeed to part 2, but there seems to be a hurdle to part 3. And actually, ERS is at the moment looking forward to all the participants. What are the main hurdles? I know there are some participants here in the room. But it might well be that it's also a bit of a technical issue, that it's sometimes difficult to record your procedures. So they are now trying to make it as easy as possible, for example, to make use of iPhone videoing possible, as long as it's anonymous. On the other hand, sometimes we also have participants that do not have EBUS yet available in their own institution, so they need to look for another institution to be hosted and to make their recordings there. So that can obviously be a hurdle. So I think it differs a bit among the participants, but actually it's a guess still, but I think these are the main two ones.
Another question maybe? How many scopes are do you use in the Netherlands? For how many people, how many inhabitants, and how many scopes?
I really don't know, but you know, it started, EBUS has quite rapidly spread over the Netherlands, and all oncology centers, and these are quite a lot, do have EBUS scopes. So this I think is quite a lot, actually.
Quite a lot.
But also because it's not only important in lung cancer staging, we also use it for all types of mediastinal nodal enlargement. Also, for example, in our hospital, we are National Referral Center for esophageal cancer. And actually, it sounds a bit strange, but these doctors mostly ask us as pulmonologists to assess their lymph nodes in esophageal cancer. Because we have a broader reach, we can add the EBUS to the EUS procedures. So the thing is also that as soon as you have your EBUS practice running, you will see that there are many more indications than you thought before, actually. Mm-hmm. Yeah.
Okay, thank you very much. Many greetings to Netherlands and to Amsterdam.
Thank you.
Thank you very much. Ευχαριστούμε πάρα πολύ.